community health workers who mainly administer the informed consent. When you take consent, do you tell them the details of the project and what's in the syrup? What are the advantages and disadvantages to the participants?
Yes, we tell them that for low dose they infants will give medicines and it will benefit their children.
Do you know that the placebo is being used in half of the participants? दवाई में शायद दवाई शामिल ना हो, ये आपको पता है?
No.
When we ask the research medical officers about their views on the process of informed consent, during the day when we asked the research subjects, the community workers, the community elders and the community leaders, nobody is aware that this is a randomized controlled trial, placebo-controlled trial. This is a randomized placebo-controlled trial. Do you think that this is misunderstanding or this message has not been communicated, or if this message would have been communicated, this would have resulted in people not participating in the study?
Actually, we are also not aware of the randomization. So we are also not aware of the which medicine contains the actual drugs and which is the placebo.
That is true. But you know that this is a randomized placebo-controlled trial. Somebody is getting no medicine.
Yes.
You know that. That's one of the two patients will not get the medicine. That you know. That's randomization. But the patients and the community and nobody is aware of that.
Yes, it's true.
But why? I mean, they should know. They ought to know. That's their right to know.
Actually, the community leaders know these things, but the community also don't bother to be aware of this type of things. And some of the community leaders also know that some of the children are not getting the medicine of this malnutrition. The leaders know.
But don't you think as a researcher it is your responsibility that they should know when they are consenting, before that they should know that they are picking up a draw in which one person will not get the medicine and their child could be one of them who's not getting the medicine?
Yes, you are right.
Suspected from the beginning. I think some of it thought that they were not telling them the truth.
Yeah.
Okay, Lillian, what do you think?
Okay, I think the researcher was not telling all the details. Rather, maybe the researcher didn't explain everything to these community elders. Or rather, these community elders didn't understand all the concept of this research. But they have a way to convince these community members to participate in this research, despite them not having all understanding about the research. Like the elders, they are convinced that this research is for full beneficial to the community, of which they are not sure. From whatever I've watched, they are not sure. Like the elder is not sure whether it is full beneficial, like it will fully benefit the community members. But he's trying to convince his members to participate, despite him not knowing whether it will have risk on them or not. For me, I say it is not right. As an elder, maybe a community elder, maybe the researcher could explain to the elder. Then maybe the elder helped the researcher to explain to these community members, so that if they understand the concept of the research, let them give the consent to participate. Let the researcher with the help of the community elder, explain all the limitation or the benefit and the risk in the research, and allow these community members to give their consent if they are ready to participate. I think if the researcher did that, it would be better.
That will be different. Okay. Thank you, Lily and Diana.
And then the fact that those people who are giving the concept, some of them, like the community workers, they don't know if the medicine will work. I think it says a lot because the people who participate don't know the information.
Yeah. So, the community workers should say, isn't it, that first of all, we are doing an experiment and we are trying to answer a question and we don't know the answer to the question, but we are using you to answer our question. And what is our question? Is can we improve birth rates? And we're going to give you something, and some of you are going to get that which should improve birth rates, and some of you are just going to get water. You're going to get nothing. You're going to get something that is not going to make any difference. I think people are afraid to say that because they feel that people will not enroll in the study. Why do you think they wouldn't say that? Before I hand over to Nadu to close up this session. Why do you think those researchers were seemingly unconcerned that these people understood that they were getting placebo, that they were getting the real drug, that there were any risks? Why do you think that is the case?
Maybe I may try. Maybe this researcher thought if at all he tells the community, like the participants the truth, they may refuse to participate. So all he wanted, or the researcher wanted, is like the researcher was not after the benefits that these members, participants will get. So all he focused with is the research. He don't care whether it is true or not. Like, yeah.
Okay. But remember that in research, you are not, the point is not to benefit your research participants from what you're giving them. The point is to benefit them from the knowledge you're going to get. So as a doctor, you would never give, well, maybe you might, I hear there's something called the placebo effect, but as a doctor, you would not give something that doesn't have any medicine because you're trying to answer a question. You want your patient to get ready, to get better. But as a researcher, you would, wouldn't you? Yes? As a researcher, did you give somebody placebo? Yes, you're trying to answer a question, and you feel that question is going to be beneficial to very many people. That once we find out if this drug works, then more people can be on it and we'll all be getting better. Is that not correct? It's such a difficult thing to do, especially for people who every day you wake up to make people better, to realize that you can actually do something that you know will not make them better. Because you know that some of them are getting placebo, so you're wearing both hats. Anybody else want to hazard a guess why those researchers were saying things while they were smiling? No, they didn't know. They didn't seem to be concerned.
Probably the role of ethics committee on site in that particular region, or maybe it is all over, is not quite illustrative. It is nothing that is being put into effect, and that will make me pose a question. Does the committee have any responsibility on site?
Yeah. We'll talk about that on Saturday morning a bit. Yes.
It's all about they have the right person for the research. They think they have absolute freedom in that community because they have pocketed the community.
Yeah. So you must have oversight. After you approve, I think I gave a seminar on post-approval monitoring. I don't know if you were there. There are some things that I did it online, so maybe some of you didn't attend, so we'll repeat it. But yes, it doesn't end with your approval. And that is why you give approval for 1 year only, so that they can give you a report. And sometimes you will just pick up your legs and go to where they are and find out if they're doing things the correct way. And many studies have been closed because people are not doing things the right way. And the beauty of doing monitoring is that you only have to do it 4 times a year. But nobody knows who's next. So people tend to improve even before you've reached them. Because they're like, they might find me, you know what I mean? So we saw a big difference towards research integrity when we started being monitoring. Because as somebody once said, people do what you inspect, not what you expect. So just that, you know, just that fear that somebody can pop in at any time, made people really try at least, you know, to be faithful to their protocol and to do things, you know, almost like the book. Of course, you can't be perfect. Yes, Anne.
I just want to say, maybe what if they are getting some monetary or some incentives?
Yeah.
The community leaders are getting incentive, the researchers, everybody is getting, so they must make sure that women participate. Yeah. So maybe that could be a drive to them not caring about the study per se, but caring that it's actually done.
Okay. So do you think that this study ended and people got data?
You mean the participant community got
Yeah. Did they continue? And the investigators, do you think it came to the end of the life cycle of the study and then actually they got data? Do you think the researchers got data?
Like, the amount of questions should be, did they get data or is it quality data?
Just did they get data? We shall move to quality data, but did they get data?
I think if there was no Iserc or anyone to fight on their behalf, on behalf of the participants, then probably they finished.
They did, yes.
They went through.
They did finish their study. They did. And they did publish. And they did say that taking folic acid X amount of times actually helps with the weight of people. They did. And people have used that information to continue giving folic acid. They do, up to date in Pakistan. So now that we know they got the data that they published and that is helping people still, does it matter that these research participants concluded?
It does.
Why?
It absolutely does.
Mm.
We sometimes say that the end justifies the means, but that is not always true. If you ended up being very rich and helping a lot of people with that money, it's a good thing. But if you got that money with blood on your hands, does that make that a clean thing?
Now you're talking kind of action. So the blood is going to follow you or what?
Which of my theories is that?
Sorry?
Which one?
Which underpinning of the theory are you using?
Consequentialism, deontology, or virtue ethics?
That's true. It might be consequentialism.
So, yes, can you ask?
We have the impression that the community is quite poor.
Yes.
And I want to bring into Kenya, where such communities would also expect to be given a relief food.
Yes.
And the distributor of the relief food is the chief.
Yes.
And now we are going to use the chief to convince them to give consent to the research. I don't think we will get something fair there. So my suggestion, if it wouldn't do any harm, is that the researcher could maybe train a few of the caliber of that poor community, so that he could use them to reach out to the other people. That if they understand, then they can talk to the other people and then they participate without being compelled or without being coerced.
Thank you. Thank you very much. So I want to hand over to Nano to round down the day and to also give her thoughts about what we've just discussed. I would like to thank you very much for your participation, and I'm very happy that these questions will remain in your head.
We want to appreciate Mrs. Benji especially for taking the factorial club from 5 all the way to 1. All right, let's start. Well done. Thank you so much. She's exciting. And that was a very nice way of communicating the key concepts that we want to cover this afternoon. Now, some of the things I was noting: who does the recruitment? Who does the consenting? Actually, who identifies and then recruits the potential participants? Who consents? Who collects the data? Yeah. Then there was the issue of the therapeutic misconception. Is the participant, when we have a clinical trial, understanding that there is standard of care, and right now, at this moment in time, they are actually in a research project as opposed to being in the regular standard care? The question of vulnerability, there were issues about comprehension, literacy. By the way, illiteracy is not a reason for a research team to give an excuse for not making efforts to communicate the research fully. We've been encouraging, in those types of populations, we encourage the PIs to use video clips, to use pictures, to use diagrams, you name it. Just because I'm illiterate doesn't mean I'm stupid. That's the argument we have now. You need to come down to my level and figure out how we communicate in my community and come up with a way to make sure I have understood. There was a study being done in Eldoret where they wanted to get breast samples from women who had no issues with breast cancer, but they wanted women to come and volunteer so that they could have a big biodata biobank in India. And one of the questions that came up was, how do we break this down to the point that people really understand, first of all, it's not very invasive, it's not very painful, and that you're not sick, you've not come for care, but can you please come and they did a mini video to even show the procedure. So we need to encourage our PIs when they come to us and they're saying they will work in a population where people are very vulnerable, barely can speak English or Swahili, they still need to tell us how they play, because we have all other languages available, and beyond language itself to using graphics and things like that. Then there was the issue of undue influence, like the example I also gave in the morning. The immunosuppressed person with TB was so sick, they were just happy to get a pill and to get the tea and mandazi when they came for care. And so it's similar, you could see that trend. But I think the role of the PI and the research team and the research assistants, you could see, everybody felt they could have done a bit more, isn't it? Then the training of the research team. First of all, we discourage using healthcare providers as part of the recruiting team. You can be part of in the site, but employ a liaison, someone between your team, a research assistant between the clinic and the participant. The nurse can say at the end of the clinical encounter, oh, by the way, there's a study going on diabetes, and you may be eligible. Are you interested? If they say yes, you tell them, just round the corner, room number 7, there will be a research team member there who will explain to you. That's okay, the ethics committee allows that. But I should not be the primary physician who sees this person with diabetes. Every clinic he comes, I should not be the one recruiting them. There is undue influence. And so this thing about saying the community health workers and the clinical officers and the medical doctors were doing the consenting was working. We discourage that totally because our patients, like I said in the morning, they look up to us who are in academia, but also to us who are giving them care. And so they may not say, you saw her saying, but they came to my house, how can I say no? Oh, but they called me, how can I? But imagine your own nurse who gives you a medication and sees your baby and where's your baby is inviting. They always, I have a slide I will show you tomorrow, where they say, I trust my doctor. So they will, we who are on this side of this divide need to be conscious of that. And when that protocol comes to our IRB, we need to remind the PI, please, if your budget can allow, you need a liaison in the community to help you recruit. We have used community health workers to identify and recruit for us. Maybe we are looking for traditional birth attendants for that study of mine, the one we keep using as an example. Why did they deliver at home? You can use it to help you find, but not to consent. They can do the same way the nurse or the doctor will refer the potential participants to the research team. Then there's the issue of our earlier, prior, pre-existing relationship with the research community. You can see in that site, just like Majengo, the researchers and the other places, we keep going so they know us, they've heard of us. So even the elder, when you show up, you say, oh, you finished the study on malnutrition. What do you want this time? Is it HIV or diabetes? They're already in your shoe, in your boat to go. So we, in fact, many journals now are asking us as research teams to write a paragraph about our existing and prior relationship with the community of research, as we call it, especially in qualitative research, so that they can take care of the reflexivity. They want to see the level of bias and how we as a research team mitigated against it. So when you see a protocol like that again, and someone is saying, you know this person works in the NCD clinic, they have brought a protocol on diabetes, they are saying they will recruit, we need to remind them that they have a pre-existing relationship with the clients and the families of the clients, and it may affect the work. There is another place we take those community health workers, community advisory boards, community advisory groups. They do very well there, and that's okay. They still talk about the study. You can give them information sheets to go and share in the community, but again, they are just creating awareness about, oh, there's a study, the cleft lip, oh, there's a team coming to fix the cleft. The same way they do that, they can go and talk about, oh, there's a maternal vaccination clinical trial coming at the facility X. There is more information available on Fridays there at 2 p.m., whatever, that's okay. So they can be part, and you can use them also to communicate when there's news, but don't use them for the research. We had in Kilifi a community health worker who actually came and sat in a focus group discussion, and we didn't know. The moderator didn't know, but they noticed each time they posed a question, everybody turned to that corner to look at them. They waited for that person to answer before anybody answered. And it's later that we realized this had happened. I don't know whether they came because of the tea or the transport, because they didn't fit the criteria. So as you know, a focus group discussion should be 100% homogeneous based on the research of interest. That's for another day. But yeah, that kind of person should not be there. And lastly, an example from Kilifi, and something you can consider. They just mentioned to me, they have, you know how you have a grant and it has exchange gains, so some extra money that you can convince the sponsor to allow you to use in a new way. They want to run a session like what we are doing for the Kilifi County Research Office. Because in Kilifi, not all counties are doing this. Once you have now the ethics committee approval and then a cost permit, before you collect any data in Kilifi, now you go with those 2 letters to the Kilifi County. And they still say we have to review. They ask for the protocol and all that, but when you've been having this pre-existing relationship, they seem to clear you faster than when you're new, because they know how you work, they know you're always, But the fact that this happens, and sometimes there's a lot of delay. So what this particular PI was calling me to say, we have a bit of a pocket. Please, can you come here for a day? We want to capacity build the community, this particular stakeholder in the research process, in the research chain. It's so, I looked at that elder and I could imagine someone saying, hey, we want to build to enhance understanding about studies or research or what is a placebo, those types of things. And it's things to think about, how we can go beyond just doing research, almost helicopter research, like you're saying, they finished, they went and published, and the information is being used elsewhere. Going back and saying, this is telling me, has this changed in 2025? If it hasn't, can I use some of my exchange gains or some work I'm doing in Pakistan to go and build capacity? Those realities. So I invite you to start thinking like that. What can you do in your catchment area in small ways and big ways to enhance understanding of what is research, what is a placebo, what is an RCT, and these kinds of things. All right? Thank you very much. Thank you. Back to you.
Last
It's a question. It's a question
For me,
for you.
Okay.
If a healthcare worker should not recruit and should not take consent, yes, then who does?
You employ research assistants and you train them. Actually, for all my projects, I have a minimum of a 2-day training. Most of them are 5 days training, full, like from what we're doing now, 8:30 to 4:30. We read every consent form, line by line, in all languages that will be used in the study. If there's Meru, Swahili, and English, we do it. We go through every tool, line by line. But day one in the morning, we go through, there will be a PPT presentation on the whole study, from the gap, the methods, the population of study, the sites, the works, everything. So a PI or a co-PI and the study coordinator must be there, even if you have subcontracted the training to somebody else. And what happens is that by the end of that training, like what we did, we had a 5-day training for the 47 county study I mentioned, where we recruited I have a database of arrays across the country actually. So, but we needed more people. So we had to add, and we added the young doctors who had not done research. We trained them for a week. The reason you want to have someone neutral is because you want to reduce that undue influence or coercion. And then you want them to feel free to ask questions in different ways. Sometimes they may feel, intimidated by a doctor or by a nursing officer. So a lot of my research assistants are diploma level and first degree level. When I use a master's or PhD, like I have a postdoc right now, it's when I'm doing interviews with very senior government officers or Ministry of Health in Nairobi, things like that. But regular Joe, I'm recruiting mothers in ANC and all that. I have a whole database of diploma holding and degree level research assistants. And what I keep doing is, you don't, because when you teach them how to do consent and the importance of, I don't want to lose them, but I keep adding young people, more people to the database. But when the people I have already trained are available, I always check. I say, oh, we're going to the Mulima. Are you available? We'll be collecting data. And do you have any other arrays you are aware of that we can train? But we must train them for every new project on that project. And there's what we call refresher. If we will be using in-depth interviews, I will always do a refresher on how do you do a good in-depth interview and all that and all that. And there will always be someone who's a little bit green. They're new completely, and we match them with a seasoned qualitative researcher and things like that. Yeah.
So now for like our setup in Chogoria,
yes,
you're getting proposals from residents,
yes,
or
yes,
fellow doctors, nurses.
Yeah.
For them to collect that data,
yeah,
which probably would be maybe like a hospital-based data.
Correct.
It would still have to happen.
They need to employ, they need to budget a research assistant. But if it's secondary data, for instance, they miss even that. We've been asking the PIs to budget the person who's going to retrieve the data for you, even if it's someone who works in the hospital.
As long as it's not a healthcare worker.
No, I mean secondary data, it's okay. It will be, what do you call them, the health information officer, but you need to put FTE time for them. Yeah, so they may need a day, a week, for 1 month to retrieve your data. You need to pay for that, even if it will go directly to their salary. That is something the hospital system should require of the PIs. It shouldn't be free. But you can employ an undergraduate or a diploma nurse and other people to be the in-between between. It can be, what I mean is, it could be a student in the nursing school. I train them, I need 2 arrays to do the in-depth interviews. You train them to do that work, yeah? For you to recruit and do that and everything. But what I'm saying is, this is a diabetes clinic. I'm doing a study on diabetes. I'm the nursing officer in the diabetes clinic, or I'm the MO who sees those patients. I should not be the one recruiting them and consenting them. But I can say, oh, and Mary, by the way, on your way out, there's a team, there's a young lady out there, she's in a yellow dress. There's a study there, that is running on diabetes. Just go see if you're interested. You can do that referral, but you cannot recruit, because there will be coercion and undue influence. Yeah. Does that help?
I think it does, but it's very different from the way when I was doing my master's, when Moses was working with the earth. That's when I did my master's. They really insisted that you couldn't hire anybody. Do you remember? We had to do everything ourselves.
Yeah, even now, someone called me to ask me this thing about having an array and this study. I said, I'm not telling you you're not going to do your study. It's still your master's. But for instance, when you run IDIs, you have to set up the place, you have to clean up things, you have to buy the stationery and all that. That when I send an assistant, does that mean that I'm not doing my work? You still have to engage with the data. You still have, we encourage you to have a biostats on board early. You're learning to do research, but you must work